Thank you for joining our colorectal cancer prevention community events. My name is Stephanie Wells, and I'm from Mike and Steph in the Morning on B104. This event is held every March in honor of colorectal cancer awareness. And this evening, we will have the opportunity to learn about the importance of screening, also risk factors and prevention strategies, along with taking a look at genetic components of colorectal cancer. For some general housekeeping rules, I want to let you know that all participants have been muted with their video cameras off upon entry as a way to eliminate feedback and distractions throughout the program. We greatly encourage you to ask questions this evening, so if you have a question to ask, you can use the chat feature, which is located on the right side of your screen. You will select the option to send your questions to all panelists. Again, you want to send them to all panelists, and this way they will be sent only to myself and the providers this evening to ensure confidentiality from other attendees. You can address your questions to a specific provider if you wish, or you can ask a general question, and we'll make sure to direct your question correctly. This program will be recorded and will be made available to watch again at a later time. Finally, when you exit the event this evening, at the conclusion of the program, a survey will pop up, and if you could please take a few minutes to fill that out, it would be greatly appreciated. We value your feedback and always use it when planning future events. I'd like to now introduce you to some of our physicians and professionals from Lehigh Valley Topper Cancer Institute, Colon Rectal Surgery Associates, Eastern Pennsylvania Gastroenterology and Liver Specialists that'll be participating this evening. Dr. Linda Lapos, Chief of the Division of Colon and Rectal Surgery at Colon Rectal Surgery Associates, PC. Dr. Magid Khalil, Hematology Oncologist for LVH Hematology Oncology Cedar Crest. Andrea Smith, Manager and Senior Genetic Counselor for the Gregory and Lorraine Harper Cancer Risk and Genetic Assessment Program. Dr. Usman Shah, Chief of the Division of Hematology Medical Oncology for Lehigh Valley Topper Cancer Institute. And Dr. Matthew Sullivan, gastroenterologist for Eastern Pennsylvania Gastroenterology and Liver Specialists. To start off the program, you are going to be hearing overviews on topics such as colonoscopies, prevention of colorectal cancer among young adults, and how family history plays a part in colorectal cancer incidences. Following these presentations, attendees will have the opportunity to ask questions of all of our expert panelists this evening. First, we'd like to hear from Dr. Linda Lapos on the best way to prevent colon cancer. Welcome, Dr. Lapos.
Hello, welcome everyone. I'm Linda Lapos, a colon rectal surgeon affiliated with Lehigh Valley Health Network. My partners and I treat all types of cancerous and non-cancerous colon rectal problems, but my passion is really preventing colon rectal cancer. Next slide. Colon rectal cancer, a few facts. First of all, someone asked me, what really is colon rectal? Well, it's the large intestine, and the large intestine involves the colon and the rectum. You can find out more about that if you need to. Some facts about colon rectal cancer. Colon rectal cancer is the third leading cause of cancer deaths in the United States. Most cancers of the colon and rectum occur in people who do not have a family history. You're at greater risk if you have a family history of colorectal cancer, but it's very common even in people who do not. And we're finding more and more younger people who are getting colorectal cancer, unfortunately. And important here is most colorectal cancer begins as a benign, non-cancerous polyp, and you may not have any symptoms at all. Most polyps can be removed with colonoscopy and will not progress to cancer. So that's one of the reasons we really emphasize screening. So what is screening? Screening in general is testing for a disease or condition in a person who has no symptoms and no other abnormal findings. The goal is to make sure you can find any problems soon, early, and they can be addressed quickly either before they become cancerous or if it's a very early cancer, they can be treated well. Some examples of screening other than colorectal are a mammogram to detect breast cancer or PSA level to detect prostate cancer. So why screen for colorectal cancer? Well, colorectal cancer is highly curable when it's diagnosed early, especially when we can diagnose it before any symptoms occur. And colorectal cancer is also very preventable because most colorectal cancer starts as a precancerous polyp, and the polyps can almost always be found and removed when you have a colonoscopy. So who needs colorectal cancer screening? Well, for so-called average risk adults, and I'll explain a little more about that, it's now recommended to begin your colorectal cancer screening at age 45. And that is a new recommendation. And the reason is because we've been finding more cases of colorectal cancer in younger people. So-called high-risk individuals, and I'll go over this, may need earlier screening or more frequent screening. Now, some people say, if I'm elderly, do I still need it? And for people 76 to 85 years in age, the decision to screen for colorectal cancer is usually determined on an individual basis. And you can decide this by discussing with your primary doctor or with your gastroenterologist or colorectal surgeon. So what are high-risk individuals? Well, these are the people who maybe already have had a history of precancerous type of polyps that maybe were removed, but they still could go on to have more. Or a person who has a history already of colorectal cancer that underwent treatment, or of certain other cancers that may make you more prone to having colorectal cancer. Patients who have ulcerative colitis or Crohn's disease are also at higher risk for colorectal cancer. And also anyone who has significant family history of colorectal cancer in relatives, or colorectal cancer, polyps, or of certain other cancers. And those are individuals who may need sooner or more frequent testing, such as colonoscopy. So the recommendations, current recommendations for colorectal cancer screening for so-called average risk people, not strong family history and that sort of thing, is to do a colonoscopy every year. And that's considered the single best preferred strategy by some of the major medical organizations. And then, as I mentioned, the new recommendation is begin at age 45. There are other recommendations for colorectal cancer if you're of average risk. For example, there's the so-called FIT test. A sort of different name for it is Hemoccult, fecal immunochemical test. And that's generally considered the second best choice, especially if a person declines a colonoscopy or if they happen to be in a remote region where colonoscopy isn't really available. It's a home test where you put a sample of your stool and it's sent off, and then they test. And this is mainly testing for microscopic blood in the stool. Now, that doesn't mean 100% that you'll have cancer. However, that can be a sign of cancer. Now, for this particular test, you have to do it yearly to get the right recommendation. It's also not indicated for any people who have any known rectal bleeding because the test will just turn up positive. And also for anyone who is at high risk, if you have a history of polyps yourself or family history, whatever. If the FIT test, the stool test, is positive, then the next step is do a colonoscopy to try to get a better idea of what's going on and hopefully try to fix it. There's an alternative test that you probably have heard of called Cologuard, and that one is actually, it's a combination of two tests in one. The one is the FIT test, the test for fecal blood, and the other one is a test for fecal DNA. The Cologuard test is very good at detecting colorectal cancer, not as great at detecting small polyps as a colonoscopy would be. The result that you would get back from the test is either positive or negative. And of the two tests, the blood and the DNA, it doesn't really ever tell you which one is positive, which one is negative. It just says one is normal or one is abnormal. And if the test does turn up positive or abnormal, then again, have to go through a colonoscopy. That's the next step to try to really discern what's going on. Now, for the Cologuard test, it's recommended that if that's the test that you want to do and it turns up normal, you should do it every 3 years. And it's definitely not a test that's indicated for people who have any rectal bleeding or those considered, again, high risk, as I mentioned before. And there's still more research needed, to kind of discern exactly how accurate the test is and if it's really the best test. So as I said, colonoscopy is really considered the gold standard test. It's considered the best test for detecting colorectal cancer and polyps. And it's also important for patients with symptoms, such as people who have rectal bleeding, change in bowel habits, etc. Now, again, that's not considered screening, but for someone who has those types of symptoms, colonoscopy is very often the next step to try. One of the good things about colonoscopy is that polyps can be removed almost all the time, immediately during the colonoscopy. And if there's any other abnormal tissue, like a suspicion of a cancer or something, it can also be biopsied right away, and you can get the result right away. And another good news is that for a person considered average risk, it's acceptable to have a 10-year interval. So if you have a colonoscopy, no family history, no significant symptoms, and your colonoscopy turns out normal, you're usually okay for 10 years. So a few other advantages of colonoscopy. Well, one thing, the prep is improved. Most people think the prep is the worst part of the whole procedure, and it actually probably is. However, there is definitely some improvement. There are, it used to be a big, gallon jug that you had to drink. Now it's usually less fluid and sometimes even pills that you can drink. And it's usually done in stages, so you don't have to kind of drink quite as much. So there's no doubt that that is the part people like the least about the colonoscopy. But most people are able to, just get through it. And then, as I say, be glad when they're done with it. Also, another advantage is that there's very safe, comfortable anesthesia involved. You do, of course, have to have somebody drive you to and from the colonoscopy because you will be just a little bit drowsy afterwards, but very safe and generally very comfortable. Another advantage of colonoscopy is that screening colonoscopy is covered by almost all insurance plans. And another one is that when you have a colonoscopy, almost all polyps can be removed immediately during the colonoscopy and then will not progress to cancer. Because as I mentioned, most colon cancer starts as a polyp. So get rid of those polyps, and that way you'll get rid of any chance of cancer. And also, if you're considered, as I mentioned before, if you're considered low risk and your colonoscopy is normal, then you're good to go for 10 years. So other people have asked, what about COVID? why should I have a colonoscopy if in the COVID pandemic, of course? And it's certainly understandable that people have those concerns. However, I will say that all COVID safety precautions are taken very carefully at the endoscopy centers and the hospitals. I have never heard of a patient who got COVID at the time of having a colonoscopy at the hospital or an endoscopy center. Unfortunately, I have seen quite a number of patients in the last couple of years who put off their colonoscopies, either for screening or maybe even because they had some bleeding or other symptoms, and unfortunately had problems with very serious colon cancer or rectal cancer. So I would say it's certainly much safer to get your colonoscopy than it is to delay it and get colon cancer. So that's all I have to say right now, and we'll be answering questions later. Just mentioning the 45-year-old birthday there. So right now, I'm going to hand this over to Dr. Maged Khalil, who's a hematology oncology physician, and he's going to talk about early onset colorectal cancer. Thank you, everyone.
Hello, everyone. This is Maged Khalil. I'm one of the medical oncologists at High Valley, and myself and Dr. Shah, who's also in the panel. We primarily take care of GI oncology, a big practice of colon cancer. I have to tell you that the last many patients I saw in my practice, they were somewhere between 40 and 50 years of age. So this is becoming a very hot topic that need to be talked about, which is why do we have increased incidence of colon cancer in younger people? Nearly 18,000 people under age of 50 would be diagnosed with colorectal cancer this year in the United States. Of course, some groups were had more than others. You can see increasing incidence among Alaska Natives, American Indians, and whites. Still, the African American have higher or more likely to develop colorectal cancer in younger age than whites. However, this gap has been shrinking lately. The same trend is being noticed in Canada, New Zealand, Australia, some other areas in Asia and Europe. Most of these places, the number of cases of younger adults started to trend up even since 1995. This slide, you see the rising incidence of colon cancer in younger adult. And you can see that actually while the numbers are decreasing on people above 50 years of age because of screening, you can see the number is increasing in younger adult. Emerging evidence suggests that early onset colorectal cancer have distinct etiology from hereditary colorectal cancer and from the late onset colorectal cancer. And this increase is an increase in generation. So whenever there is a generational increase in incidence, it's most likely due to environmental exposure. However, the etiology of the increased incidence is still poorly understood. So why is colorectal cancer rising rapidly among young adults? It's the conclusion is not really known why this jumping in colorectal. However, we do know that there are some factors that raise the risk of colorectal cancer in older adults, including obesity, physical inactivity, and smoking. And some of those risk factors may have become more common over the last 45 years, along with the rise in early onset cases. So it's possible that some of these factors are responsible for the rise of early onset disease among young adults. On the other hand, there are some other factors that lead to increase the incidence of colorectal cancer in younger adults, and that's the subject where most of the researchers have not yet identified. Certain genetic conditions like Lynch syndrome and another disease called familial adenomatous polyposis raise the risk of developing colorectal cancer at young adult. However, those 10 to 20% are not rising. So those are not the reason why the disease is becoming more popular in younger population. Like I said, when the incidence of disease changed by generation, that mostly suggests more of something environmental than something biological. Most of the discussions about the possible causes of early onset disease will converge into three interrelated factors: diet, bacteria in the gut, which is also called microbiome, and inflammation. So a little bit about diet. There is mounting evidence linking an unhealthy diet, in particular the ones that are high in processed meat and fat, and low in fruits and vegetables to early onset colon cancer. How credible is the evidence behind the association of dietary factor with colorectal cancer? I will refer to only one study, but it's a very huge study that was published earlier this year. It's an umbrella review that looked into something about 45 meta-analysis describing 109 association. And this study found convincing evidence of association between low colorectal cancer risk and higher intake of dietary fiber, dietary calcium, and yogurt, and low intake of alcohol and red meat. So this study, after all, suggested that dietary factor may have a role in development and prevention of colorectal cancer. Of course, more work to be done, but that's a conclusion from a very huge study that had many participants. So the message from this study, or from multiple other studies actually, is that diet that include lots of vegetables, fruits, and whole grains have been linked to decreased risk of colorectal cancer, and diet that includes red meat, especially processed meat, beef, pork, and lamb, and hot dogs and luncheon meats and all the processed stuff have been linked to increase in the risk of colorectal cancer. Slide, please. One more. Yeah, so this is one slide that it's not my own. The reference is linked to the slide, but it's a good reminder about the high five of high fiber. Keep in mind fruits, grains, nuts, vegetables, and veggies. Next slide. So unhealthy diet have become more common in the past decades. A number of children and adults who are overweight or obese continue to climb. More time spent sitting and less time being active, more TV time linked to higher risk of early colorectal cancer. The etiology of that is unclear, whether it's because being less active or that lead to overweight. But that will introduce us to the second etiology, which is obesity, that we want to talk about a little bit. Several studies also have found that being overweight or obese may raise someone's chance of getting early onset colorectal cancer. Surprisingly, the data showed that half of the younger adults with colorectal cancer are overweight and 17% were obese. So obesity can change the function of essential hormones in the body, like an important hormone is called insulin. Another one is called leptin. The insulin is the hormone that regulates the blood sugar. And people or individuals who are obese have higher level of insulin than those with normal weight. And this will cause the cells to the cell function to change um, as the hormone continue to cause irregular cell growth in the colon, and that would lead to formation of a tumor. Also, there is another hormone that's called leptin that's responsible for inducing a feeling of satiety and cause someone to stop eating. It works with another hormone that's called ghrelin, and together they cause the balance of when to feel hungry and when to stop eating. In patients with overweight or obese, the level of the hormone leptin is like 5 times higher than a person who is non-obese. And this will lead to cell growth and area in the colon and ultimately cause or lead to a tumor. Microbiome or the bacteria that lives in the gut. Certain types of bacteria that lives in the gut has been involved in the growth and spread of colorectal cancer. They actually may affect how certain cancer treatment works. It was found that sometimes when you change the bacteria in the gut, you can change the response. In melanoma study, you can see the change in the response to treatment. So in lab studies from several types, toxins from several types of bacteria are normally found in human gut, caused cancer in the intestine of mice. And changing in the gut microbiome or the gut bacteria can be influenced by, can lead to increase the incidence of colon cancer in adults younger than 50 years of age. Gut bacteria also can be affected by the type of food we eat, the chemicals that we eat or we're exposed to, the things we drink, the things we breathe. Everything we do around us can affect our microbiome and subsequently can increase our risk of cancer. Studies shown that diet, obesity, exercise, and some drugs, such as antibiotics, can all change the number and types of bacteria in our gut, and that can lead to formation of cancer. So unhealthy diet and gut bacteria both can lead to inflammation. And in a study of mice, they found that high-fat diet can trigger gut inflammation and accelerated the growth of tumor in the intestine. Bacterial toxins, or what's known as microbiome, can intensify inflammation. And studies showed that the gut bacteria can recruit immune cells that can help cancer grow and can block immune cells that the body used to fight cancer and inflammation. Also, the bacteria in the gut can be harmful in a sense that it can lead to change on the DNA and promote cancer. Some of these chemicals also that we're exposed to that can change our microbiome can start even early in life. There are studies to show that actually things that you can be exposed to during infancy or even in the womb while you're a fetus, you can be exposed to certain things that change microbiome and eventually can lead to cancer. One also item that we need to talk about as possible etiology for cancer in younger population is chemicals in the environment. And many environmental factors are being examined as potential causes of early onset colorectal cancer. Factors include air and water pollution, chemicals in the soil and food, pesticides. Most of these chemicals are already now banned from use, but their use earlier decades could have affected people, and now we're dealing with the consequences. The National Toxicology Program identified 18 chemicals that can cause cancer of the intestine of the mice and rats. Most of these chemicals are already banned. These chemicals can damage the DNA and potentially lead to harmful mutations and lead to cancer of the colon and rectum. Other chemicals, so some chemicals can cause damage to the DNA, and some chemicals sometimes work in a different way. Like mixtures of the environmental chemicals can affect, we call it endocrine disturbers, or they call it obesogens. So things that can lead to or help change the body environment and metabolism and lead to obesity. And by this mechanism can lead to increased incidence of cancer. So these are, in a nutshell, the things that really that we need to focus on: diet, active life, and maintaining a healthy microbiome, and not overusing antibiotics and chemicals that could possibly be harmful without physicians' directions. So how do we use this? What is next? Where do we want to go with this information? It's important to define the causes and risk factors for early onset colorectal cancer. Hopefully that will help inform approaches for prevention, for screening and treatment. For instance, I would say healthcare professionals now could recommend lifestyle changes, more frequent screening tests to people who, because of their exposures, at high risk of developing colorectal cancer at young age. Now we just heard that the screening age changed from 50 to 45. Also, people who are younger than 45 can still be screened, and their screening should be tailored. Approach to each person would be based on the risk factor that the person has. So it's important to identify the causes and risk factor, so that would help the researchers and scientists to uncover the etiology of early onset colon cancer, and pinpoint specific molecules that drive the growth of cancer, and then would be easy to help to look for or screen for that molecule and find it. For example, some screening tests check for specific molecules made by colorectal cancer or polyps. And knowing which molecules are the key for the growth of early cancer can help design screening and diagnostic test or even therapy. Having said that, I want to share with you this one slide here. At Lehigh Valley, we participated in a national trial. This is a publication that was in the Annals of Oncology, and Lehigh Valley took part of the authorship. Was a study to look for identifying early cancer by looking into circulating DNA, and this circulating DNA sequencing give information to potential detection of 50 different types of cancer across different stages. So these are the type of screening, the future screening, and ideas of how to find a molecule or a sequence that you can find early in the blood and detect it before it becomes evident on the scan. So all what we talked about is important, but we first, all of us need to be have more awareness and be aware of the issue, and not to underestimate any symptoms, address them right away. And if you haven't had your screening, maybe that's the time. We all need to be aware that cancer of the colon is not for elderly. It's no longer the case. We all need to be tuned and more familiar with looking more into our stools, and anytime you see a change, should be addressed right away. With that in mind, I will pass on to Andrea Smith from genetics, who will talk to us about the hereditary colorectal cancer.
Hi, I'm Andrea Smith. I'm one of the genetic counselors with the Topper Cancer Institute. And I just want to take a few minutes to talk a little bit about hereditary colorectal cancer. So Dr. Khalil and Dr. Lapos both talked a little bit about risk factors for cancer. And one thing that they had both mentioned was family history or hereditary cancers. So that begs the question, how do you know if your cancer is genetic or not? How do you know if you're at increased risk? If someone in your family had cancer, what does that mean for you? And that's where genetic counseling and genetic testing can certainly help answer some of these questions. So first, what is hereditary colon cancer? So hereditary colon cancer is that about 5 to 10% of colon cancers that we can link to one specific gene that runs through the family. These are actually caused by mutations in genes, changes. And there are several different hereditary cancer syndromes caused by many different genes. I have some of them listed here. The most common is one called Lynch syndrome, used to be called hereditary non-polyposis colorectal cancer syndrome, or HNPCC, because we don't tend to see a lot of polyps with that one. But then we also have some polyposis syndromes, like familial adenomatous polyposis syndrome and MUTYH associated polyposis syndrome, and there's juvenile polyposis, Peutz-Jeghers syndrome. There's many of these syndromes, and they can all lead to much higher risk of colon cancers and other cancers. So why might it be important to know if you have a hereditary cancer syndrome? It can certainly influence treatment. So if you've been diagnosed with a colon cancer, it might impact what surgery is recommended. So for individuals who have these hereditary cancer syndromes, we know that they might be at increased risk for a second colon cancer. So maybe we would consider a larger surgery, removing a large part of the colon or even the entire colon instead of just where the tumor is. There are also medications that might work a little bit better for people who have certain genetic mutations. It can also help make screening recommendations. So for individuals who have these hereditary syndromes, oftentimes we want to start screening earlier. So we might do colonoscopies in the 20s or the 30s, and we do them a lot more often, even up to every 1 to 2 years. There can be some preventative measures that we can take for individuals who have high risk of colon cancer, including medication. There have been some studies that have shown that a daily aspirin might help decrease risk of colon cancer, especially for those at very high risk. And again, sometimes we even consider preventative surgeries. And not only is this information important for someone who has been diagnosed with cancer, but it can also be very important for their family members. So they could give this information to their children, their siblings, nieces and nephews, their parents, to help know if they need to have some increased screening as well. So the first thing we need to do is gather some information about the family history. As a genetic counselor, my most important tool is the family history, what we call a pedigree. So when we look at the family history, we want to go to at least third-degree relatives. So that's going to be parents, siblings, children, grandparents, aunts and uncles, and first cousins. And it's really important to know how old people are or how old they were when they died. Are they in good health? Do they have any health issues? Particularly, were they ever diagnosed with cancer? And if they were, what type of cancer did they have? How old were they when they were diagnosed? Sometimes even knowing what their treatment was can help give us some information. Or if they have other findings that might suggest a higher risk of cancer, such as precancerous conditions, colon polyps, certain skin findings, anything that we know can also be associated with some of these different hereditary cancer syndromes. Lifestyle factors can be important. As Dr. Khalil mentioned, there's a lot of lifestyle factors such as diet, exercise habits that can certainly impact someone's risk of cancer. And these are things that are often common in families. So sometimes we might see colon cancers or other cancers cluster in a family not due to genetic factors, but maybe shared lifestyle type factors. Ethnic background or country of origin can be important because we do know certain ethnic backgrounds are more likely to develop cancer, and certain hereditary cancer syndromes can be more common in certain ethnic backgrounds, such as the Ashkenazi Jewish population. And it's important to know for those people who have passed how old they were when they died. If I'm looking at a family and everyone lived to their 70s and 80s with no cancer, that's very reassuring. But maybe if someone has a very small family, or if individuals passed away from accidents due to very young ages, we don't know would they have gone on to develop a cancer or not. So how do you get all this information? Easiest way is to talk to your family members. So whether it's a family reunion, a holiday get-together, a big family vacation, ask your relatives, how has your health been? Maybe you heard they were diagnosed with cancer. Talk to them about their diagnosis and what their treatment is. Or maybe their doctor told them, hey, share this information with family members. One of the biggest tools we have is just that knowledge of family history. Maybe family members aren't around to talk to, or you're not close with your family members. What are other ways to find some information? Genealogy can be a way to find out some information. There's a lot of resources online now to help track down different family members. Things like family Bibles, baby books. Those are often areas where people will write down information about the family. Death certificates can be very helpful. And again, sometimes you can just find these on things like Ancestry.com, or certainly you can request them. But a death certificate will always list if someone had cancer, even if it's not what they died from. And of course, medical records can be very important to help identify, did someone have cancer, what type of cancer that was. Once you get all this information, there are some good tools to help organize it. Online, there's the Surgeon General My Family Health Portrait, and also the Genetic Alliance Family Health History, which can really help organize all this information. It makes a nice little graph of the family, and it's a place where you can really store that information, share it with family members, because once you go through all this work to collect all this family history information, it's really important that you keep that in a safe place. So what are some things that we're looking for in the family history that might clue us in as to whether or not this is a hereditary cancer situation? One of the first things I look at is age. How old was someone when they were diagnosed with cancer? When we see these hereditary type colon cancers, they're very often at much younger ages than average. So anything under about the age of 50, we consider young for colon cancer. Another clue is family history. Are there other family members who have had colon cancer? So if we're seeing multiple family members with the same type of cancer, that can indicate maybe there's a common gene that's increasing that risk. Also, maybe people in the family haven't had colon cancer, but maybe they're getting their colonoscopies and we know they have colon polyps. But hopefully if those colon polyps are removed, they're not getting colon cancer. If we see a family member with more than one cancer, so maybe more than one colon cancer or colon and stomach cancer, that could be a concern. I also look for very specific patterns of cancer in the family, so who's affected. The vast majority of hereditary cancer syndromes are inherited in a dominant pattern, where it's a 50-50 chance that gets passed from parent to child. So oftentimes we'll see multiple generations of individuals with cancer. But there is a syndrome that can be recessive, meaning someone has to have two mutations, one from each parent, so that we typically see across siblings and not going back in the generations. We might look for family history of other cancers. So each gene or hereditary cancer syndrome has a little bit different pattern of cancers that we can see with it. So we might see colon cancer along with uterine cancers, ovarian, stomach, pancreatic, breast cancers, thyroid cancers, certain brain cancers. So those are all different patterns that I'm looking for. The presence of colon polyps can be important as well. So As Dr. Lapos mentioned, we know colon polyps can sometimes develop into cancer, especially those adenomas. And if we see those at really young ages, again, that's showing that maybe someone is a little bit more at risk. And also there are some syndromes that can cause people to develop very large number of polyps, sometimes even to the hundreds and thousands. These individuals have very, very high risk of colon cancer because it's very difficult to remove all of those polyps. We can also see some very unusual type of polyps, what we call hamartomatous polyps. Sometimes these are called juvenile polyps or Putzjäger polyps, named after the syndromes that we're associated with. So if a doctor might see those on your pathology report after your colonoscopy, they might suggest coming to see genetics. We also look for other medical conditions because we know for a lot of these syndromes, we can see a lot more than just cancer. We can see sebaceous gland tumors. So these are little tumors that occur on the skin. It's actually of the oil glands in our skin. Very often these are benign and we call them sebaceous adenomas, but occasionally we can see sebaceous carcinomas, which is a type of skin cancer. We can see a very unusual feature called chirpy associated with a certain syndrome called FAP. So it's congenital hypertrophy of the retinal pigment epithelium. So it's basically a little dark spot at the back of the eye. So it's actually something your eye doctor might pick up. So it's kind of unusual to think, hey, your eye doctor might pick up something at high risk for colon cancer, but it's kind of a unique thing that they can look for. Sometimes we can see a specific type of tumor called a desmoid tumor. Again, typically benign, but can be associated with some of these hereditary cancer syndromes. And there's another syndrome called hereditary hemorrhagic telangiectasia. It basically causes the blood vessels to not form quite right. So people get a lot of nosebleeds and things like that. But it shares a gene with a syndrome called juvenile polyposis. So we can often see those two things run together. Sometimes the cancer itself can give us some clues about hereditary colon cancer, particularly a syndrome called Lynch syndrome. So again, Lynch syndrome is the most common cause of hereditary colon cancer. And there are two tests that can often be performed on tumor tests or tumor tissue that can help indicate whether or not someone might be at a higher chance to have Lynch syndrome. One is called microsatellite instability testing. So it's looking to see if these Lynch syndrome genes are working properly. The Lynch syndrome genes are the spell checkers of our genome. They're supposed to help fix damage that occurs. If this damage doesn't get fixed because these genes aren't working properly, because someone has a gene mutation, we're going to see a lot of changes in these certain areas of our DNA called microsatellites. They might be longer or shorter, and we call this instability. So that MSI, a high MSI, indicates someone might have Lynch syndrome. Or there's another test called immunohistochemistry screening. So this test actually looks for the presence of the proteins that the gene makes. So if we see the proteins expressed, so in the little picture here, the dark areas, that's a stain for the proteins themselves. So the MSH2 and MSH6, we see those dark spots. So that means those proteins are there. But the MLH1 and PMS2, we're not seeing those dark spots. That means those genes aren't working properly. So someone might have Lynch syndrome. So if you're kind of listening to all these things that I just mentioned, all these clues, and some of them kind of sound familiar, you're thinking, yeah, I do have a family history, or someone was diagnosed young, I have a lot of polyps, then you might want to consider genetic testing. So basically, this is our way to confirm if someone has a hereditary cancer syndrome. So the genetic test is actually going to analyze, basically spell check these different genes to see if someone carries that mutation or change in the gene that would put them at a much higher risk. This testing can be done on samples of blood, saliva. Once in a while, we'll do a skin sample, but blood and saliva are a lot easier. We can look at anywhere from one gene to many genes, depending on concerns about the family history. Are we seeing lots of types of cancer? Has someone in the family already been found to have a gene mutation? Then we might need to just look at one gene. But it's really important that for when we use genetic testing to know that it's not going to detect the cause of all cancers. Again, it's only about 10% or so of colon cancers that are hereditary. So certainly someone can get genetic testing, they can test negative and still develop colon cancer. So it's really important that genetic testing is just used as one part of your overall health plan. We certainly need to take into account a lot of other risk factors when determining which screening and preventative measures are really right for you. If you're concerned about your family history and interested in learning more about genetic testing, find a genetic counselor near you. We have multiple genetic counselors here that can really sit down, work through the family history, and talk about the pros and cons of genetic testing. So one question I get a lot when it comes to genetic testing is, why should I come see you when I can just order a test online? So there's a lot of these different tests online, things like 23andMe, Ancestry DNA, and it's really important to know that these tests are very different than what you get when you get a genetic test through a genetic counselor or your physician. These tests can certainly be very interesting. You can learn about ancestry, your different traits. Some of them do talk about disease risk, but these really shouldn't be used to help make medical decisions. When it comes to cancer-related genes, right now I believe 23andMe looks at three genes. So there's two related to breast cancer, one related to colon cancer. However, in these genes, they only look at a couple mutations, one that are very common, where there can be hundreds, sometimes even thousands of different gene mutations. So with these genes, it's still quite possible that someone could test negative, though they still have a gene mutation. So if you're really concerned about a potential hereditary cancer syndrome, talk to a genetic counselor. Don't rely on an at-home test. And also, if you're thinking of these testing, make sure you read about that privacy. I know it's really easy just to click that button that said, yep, I read the terms and conditions, but make sure you're reading those privacy concerns, because it's really important to know what they're doing with your information and who might have access to that. So if you're interested in genetic testing, you can certainly talk to your doctor, or you can always call our program to set up an appointment with a genetic counselor. I have our information listed there. We certainly do take self-referrals, and we see patients at Cedar Crest, Muhlenberg, Pocono, and Hecktown Oaks. So hopefully someplace close to you.
Very good. Thank you so much to Dr. Lapos, Dr. Khalil, and Andrea Smith for sharing this valuable information. And we're now going to move forward with the second half of our program, which is the panel Q&A. So our presenters will now be joined by Dr. Usman Shah and Dr. Matthew Sullivan to answer any and all questions that you may have regarding colorectal cancer. As I mentioned earlier, please use the chat box that's on the right side of your screen to send a question to all panelists, and we'll do our best to answer as many as we can. So I've got a couple questions right off the bat. This one for Andrea. You provided the information right at the end of your presentation about how people can schedule an appointment with a genetic counselor, or perhaps talk to their primary care physician and go through that route. Is that something that is covered by insurance, or is it similar kind of coverage as a colonoscopy would be covered?
Very often genetic counseling is covered by insurance, especially if there is some family history there that's concerning. If you call to make an appointment, that's certainly something our schedulers would walk you through. They can give you the codes that you can check in with your insurance, but very often it is covered. Same with genetic testing. Again, most insurance companies have different criteria based on family history and things like that, but very often if I go through the family history and I'm concerned, then it's going to meet those criteria. And the financial aspects, so insurance coverage, out-of-pocket costs, is something we always discuss at the appointment.
Okay, this may be a very basic question, but how does someone schedule a colonoscopy? And is that something that they can just do on their own, or something that they need to do through their primary care physician? Dr. Lapos?
Well, you certainly can discuss it with your primary care physician who can make a referral, but you can also call any of us who do colonoscopies, such as our group, Colorectal Surgery Associates, such as EPGI, um, uh, and actually there are other general surgeons too. I believe there's going to be a list listing all the doctors who do colonoscopies. But I would have to say the ones who do the most are our group and the EPGI group. And just give us a call and say, I want a screening colonoscopy, and we'll set it up for you.
We've gotten a number of questions regarding insurance coverage covering colonoscopies. One of them in our chat room is, are all insurance providers covering colonoscopies now at age 45? And how does a patient under 50 address this with their provider? And I believe the second question was about the evidence of polyps and should be screened sooner than every 10 years. Would this be covered by insurance?
So right now, almost all insurance companies are allowing, are covering screening colonoscopy at age 45, mainly because it's the new, recommendation. There are a few insurance companies that still have it a little on hold, but most are now covering it. And certainly you can check with your insurance company about it or talk to your colonoscopy doctor, and they'll be able to figure out if it can be covered. And I would say the ones who maybe aren't covering it quite yet will be doing so in the near future because it's kind of the standard at this point. And as far as if you have polyps, and the question about would colonoscopy be covered if you have to have a colonoscopy at a shorter interval of time, it generally is covered. It isn't always called screening at that point since you've had polyps. So it is possible that there may be some sort of copay or something like that. And it all depends on what your insurance is. But I would say for the vast majority, at least of the patients I take care of, if you have had a colonoscopy and you had polyps, and then you're told, oh, you have a number of polyps, you should come back, let's say 3 years later. For most patients, screening is still covered at that point. But again, it depends on everyone's insurance.
Very good. A question from our chat room. If my primary doctor is not an LVHN provider, can I still use their referral for a colonoscopy done, I guess, within network, within LVHN?
I could answer that if you want.
Okay. Yes, please.
It depends a little on your insurance. For most people, you can just call yourself and ask for a colonoscopy appointment. If you have a particular managed care insurance, it may be a little bit different. But even in that case, if your managed care insurance is in the same managed care network as these endoscopists, then yes, you should be able to get a referral from your primary care doctor.
Very good. We have a number of other questions about colonoscopies, but I'm going to open it up to a couple other things that have been brought up. We have a question from our chat room. How common are perforations? Someone like to answer that?
I'll be glad to answer. Oh, go ahead.
I'll join in. But so the risk factor, some of these things that can occur, they do vary from patient to patient and can sometimes depend on other things. Literature seems to quote rates that are quite rare, in the neighborhood of 1 in 10,000 or so procedures. So it's not certainly a 0% risk. These sorts of complications, unfortunately, do happen from time to time, but they are quite rare. And so certainly not something that I would say should take precedence and really be a deciding factor in whether or not getting a colonoscopy is the right test for you.
Very good. From the chat room, would someone be considered high risk if they have a family history of cancer, yet not colorectal, particularly such as a family history of prostate, lung, or brain cancer? I'll also add breast cancer to that as well.
Occasionally, there are certainly genes where we might see both breast and colon cancers, breast and GYN cancers, and say just because we're not necessarily seeing colon cancer in that family doesn't mean that couldn't be a risk if they would have that particular hereditary cancer syndrome. So again, if you have several individuals in your family with the same type of cancer, those really young cancers, that's when it's a good idea to talk to your doctor or maybe a genetic counselor to go through that in a lot more detail.
Dr. Khalil, part of your presentation brought up, it just stuck out to me only because diabetes runs through my family, insulin. And I'm wondering, is there a connection between diabetes and also colon cancer?
There is definitely there is a correlation between diabetes and most of the GI malignancies, not just colon cancer. For the same reason, I think it's just due to a suppression of the immune system. So that's and more recent data on even patients who are diagnosed with cancer and they are diabetic, they tend not to do as well as somebody who's not. So it's a problem for increased incidence of cancer in diabetics, and then those who are diabetics, they tend not to be the same if they're not diabetic on treatment. So diabetic control is very, very important, and people need to pay attention to start early on screening and treatment. It's a very good point you're raising here.
And to continue with that question, if you are under the care of an endocrinologist, let's say for diabetes, and then you're also now under the care of an oncologist because of evidence of colorectal cancer, how does that dynamic work?
We work together most of the time. I think most of the cases of diabetes are the simple cases that are being always treated with their PCP, and we've always been in touch with PCP, talking about what need to be done and exchange ideas for patients' health. Complicated cases that require more management and multiple agents and things like that, we always seek help from our colleagues in endocrinology, and communication is always open, and patients being taken care of from the two sides.
Thank you. What are the chances of reoccurrence for colorectal cancer? That's open for the panel.
So recurrence depends on the stage. So when we talk colon cancer, we're talking stage 1, 2, 3, and 4. And each stage still have their characteristics of the disease. So this is a really wide, very hard to answer question, but depends on the tumor invasion, the depths of tumor invasion into the wall, depends on the involvement of the lymph nodes, depends on the grade of the disease. So there are multiple factors, but this is actually has to be done stage by stage. So for as an example, for stage 1 and 2, they're different than stage 3, and there are more actually data of how to look at patients, not just by stage, but we're looking into other things of circulating DNA and things like that in the future. But that's very, very individual, case by case scenario.
Okay, maybe this one for Dr. Shaw. Is there any long-term medication use that could play a role, such as Protonix or omeprazole or similar medications? I apologize for the mispronunciation.
Yeah, the omeprazole. So it's right, the proton pump inhibitors. So they have been linked to certain types of cancers. Colon cancer is not particularly one of them. But I think that, what you bring up is a really important point, because a lot of us have reflux, and Dr. Sullivan can speak to this, better than probably most of us can. But a lot of us have reflux, and, we watch a commercial and the commercial tells us to take the purple pill or whatever is being advertised. But really, I think that's your body's warning system, right? And it's telling you you should eat differently. So it's not to take a pill and keep eating the same way. It is to really change what you're doing, and that can actually decrease your risk of other cancers like esophageal cancer and those kind of things. So I know I went a little far afield from what you asked about. Does a proton pump inhibitor cause colon cancer? We do not have data for that. For other cancers, potentially, but I think that the bigger point I think is also important.
Dr. Sullivan, did you want to add to that?
Certainly, I think in recent years, certainly the medicines like omeprazole and other proton pump inhibitors, that class of medications have really been a hot topic in studies and trying to see if there is any correlation or association with these medications. But I think, as Dr. Shah really hit on, the key is, there can also be some dietary and lifestyle changes that can be just as good or better therapies for chronic reflux. And with any medication, I think the key is making sure that you're on the lowest dose that does the job for the shortest amount of time. And so really making sure, if you are somebody who's on these medications, having those conversations during the follow-up visits to see, is this a medicine I can potentially try to stop, or is there other things I can be doing to help manage that?
Very good. This one for Dr. Lapos. What advice do you have for someone who is nervous to get a colonoscopy?
Well, a couple things. First of all, I'd be happy for that person to come to my office and talk to me about the colonoscopy, just so that I can reassure you that it's really much more important to get a colonoscopy and not get colon cancer than it is, a problem to have the colonoscopy. As some of the other presenters said, it's very safe. Yeah, you have to go through the preparation, which most people think's the worst part. But it's generally very safe. And most people, once they've had the colonoscopy, even if they've had some anxiety, they feel very reassured when they are told, hey, you're doing great and everything's normal and we'll see you in 10 years.
If a colonoscopy ends up showing evidence of cancer upon further tests, what are the next steps taken?
Well, the next steps would be to do studies to check for the stage of the cancer, as Dr. Khalil mentioned. And that usually involves some CT scans, some blood work, some other tests, sometimes genetic testing. And then the treatment may vary depending on what the stage is. It may be just surgery alone. It may be surgery plus radiation or chemotherapy. It may be just chemotherapy and radiation alone. So a lot of it really depends on the stage. And of course, the most important thing, as I mentioned, is, the sooner you get the screening, the less likely that you will have a very advanced stage cancer. So, treatment will be, sort of, I guess you'd say, better and usually easier and more curable.
Thank you. Maybe for Dr. Shah or Dr. Khalil, how quickly does colorectal cancer usually progress? And it seems like a kind of an open-ended question, but is there a general thought?
Yeah, so there's no one answer for this. We know that, for example, colon cancer, much like other cancers, is probably not only one disease. Right-sided colon cancers tend to be more aggressive. Left-sided colon cancers less so. There are molecular differences in those cancers. So, certain cancers are going to, by their very nature, progress much quicker than others. but the estimated time from when a polyp turns, from precancerous to cancerous might be anywhere from 2 to 10 years. And then once you have invasive cancer that has the potential to spread, then the other molecular features of that cancer will kick in and kind of predict how quickly something will grow. So that's probably the best answer that I could give without going into too much esoteric detail. But Maggot, do you want to add anything to that?
No, I agree with you. I think it's still a stage and biological feature of that tumor.
Dr. Khalil, just because I think this is such an important component to lifestyle, can you speak a little bit more about recommended diet, for example, recommended number of meat servings per day, vegetables, alcohol, etc.?
So I'll start with the alcohol because that's the easy one. I think the ASCO a few years ago have made it very clear that there is no safe level of alcohol, because we used to have a lot of controversial issues. That's the most controversial issues, whether one glass a day or this or that, and multiple literatures and publications. But ASCO have made that clear a few years ago that there's no safe level of alcohol. So that should be very clear as far as we're talking cancer prevention. As far as the any recommendation, particular recommendations about a certain amount of meat, or I think the most of the data we have is it calls against processed meat, excessive red meat. So more vegetables, more fruits, more fiber, more calcium-rich food. That's the idea. That's the message. And keep active and keep exercising. There's actually, this is a very long topic, but one of the studies, I know we're talking diet, but one of the studies that actually showed the best prevention for colon cancer after surgery, best prevention for recurrence of polyps and cancer was exercising study. That exercising 3 times a week was the most effective way of dealing with it. So keep active and eat healthy, and remember the 5 high fibers that I mentioned.
Indeed.
So Steph, if I can just add, some additional practical advice.
Sure.
So if you look at the USDA, right, the recommendation is about 30 grams or 25 grams for women of fiber a day, about 38 for men. So if you think about how many servings is that, right? 5 grams of fiber is an apple. So you're really talking anywhere from 6 to so servings a day of fiber. So if you think about it, you break it down, it's 2 servings per meal of fiber, which most of us don't get. So if you're going to aim for something, that's what I think folks should aim for, and it's easily doable, right? A piece of fruit in the morning with whatever breakfast you're having, or 2 pieces of fruit, something for 2 pieces or 1 piece for lunch, maybe some salad. You get there. You just have to plan it. You have to be deliberate. And in fact, everybody knows the animal kingdom, right? The tree of life, the boa tree. That tribe that lives around that tree in Africa, or on those trees, I should say, consume 150 grams of fiber a day. Right? They have a lot of other diseases, but you know what they don't have?
What's that?
Say that again, Usman. I didn't hear you.
I was saying they have a lot of other problems, including issues with sanitation and water purity and all these other things, but they don't get colon cancer if they live that long.
Very good. You know what? I think we have time for one more quick question, and this might be slightly controversial, but very quick answer. Is there an age at which people should stop getting a colonoscopy?
Can you answer that one?
Sure.
So the recommendation is that if you have had a screening colonoscopy and everything was normal, and you have no polyps, no family history, no other high risk features, that if you have your colonoscopy at about age 76, then it may not be necessary to have another one. However, because usually they would say 10 years, and once you get to the age 86 year mark, it's usually, not recommended. However, I think a lot of it really depends on if you have higher risk features. For example, if you've had a history of polyps, you're at more risk of it going on to become cancer. If you have a family history. The other part of it is if you are, heaven forbid, in a nursing home on oxygen in a wheelchair, then it's usually not a good idea to have a colonoscopy. But we have lots of patients who are even in their early 80s who are in great shape and very active and want to take care of their health and are expecting to live a good long time and who want to go ahead and have a colonoscopy. So I think a lot of it is sort of by choice.
Thank you so much. And I really appreciate all of your time this evening. Thank you to our panelists, Dr. Linda Lapos, Dr. Magid Khalil, Andrea Smith, Dr. Usman Shah, and Dr. Matthew Sullivan. Thank you once again. Want to let you know about some upcoming events from Lehigh Valley Topper Cancer Institute, including a free oral cancer screenings. Those are taking place on April 11th, 18th, and 25th. Free skin cancer screenings May 4th and May 17th. Advances in Kidney Cancer Care Survivorship event will be on May 10th. And Advances in Melanoma Cancer Care Survivorship, that event will be May 25th. If you have a moment, please complete the survey that will pop up at the end of the program. It'll be popping up on your screen when you exit the program, and everyone will be receiving a small gift in the mail as a thank you for attending. And thank you once again for all of your time. My name is Stephanie Wells from Mike and Steph in the Morning on B104. Have a good night.
Thank you, Steph.